My mom was 34 years old when she was diagnosed with breast cancer in 1996. She had just been married a year earlier and hadn't yet had any children. Receiving this news devastated my mom. She told my father he had married a defective person. Thankfully, she was able to recover from her cancer after a few weeks of treatment. She was, however, diagnosed a second time with cancer in the same breast in 2002, but this I'll get into more later. Because of the various forms of treatment she received, she has now been in remission for 16 years. The treatment of breast cancer has made huge strides over recent decades. In 1972, breast cancer was the leading cause of death from malignancy for women in the United States. Since then, doctors have learned a lot about breast cancer treatment and how to increase survival rates after diagnosis. Death rates in people with breast cancer have been decreasing since 1989. In this video, I will discuss how treatment for breast cancer has evolved in recent years, and I will bring my mother on video to discuss the treatment she received in the late 90s and early 2000s. In the 1960s, the radical mastectomy became popularized in breast cancer treatment by Dr. William Halsted from Johns Hopkins. This surgery included removal of cancerous breast, nearby lymph nodes, and 2 chest wall muscles on the affected side. Obviously, this is a very disfiguring surgery and has a very long recovery period. This became the typical treatment for breast cancer for a few years, but despite this, the death rates for cancer remained the same. Doctors soon realized that less invasive surgeries were just as effective as the radical mastectomy, as a study in 1977 found there were no statistical difference in survival rate of women who had this surgery versus less invasive surgery. In general, during the 60s, doctors learned a lot about how to treat breast cancer surgically. Dr. Bernard Fisher discovered in this decade that lumpectomies can be just as effective as mastectomies in most cases, and doctors started to move away from mastectomies when possible. The use of mammograms have also significantly improved doctors' abilities to understand how severe the cancer is and how best to treat that patient. In the 1960s, radiologists performed mammograms using general-purpose X-ray tubes and no compression. They captured the photo onto direct exposure films, much like a chest X-ray. These images had low contrast, and some areas of tissue appeared white due to underexposure. In the next decade, mammograms advanced significantly with the introduction of screen film mammography, which made imaging faster, required lower radiation dose, and provided better contrast in photos, making it easier to see through breast tissues. Improvement in screen film technology during the 1980s and 1990s made mammograms increasingly better. To be able to clearly see in a photo where the tumors have developed is crucial to treatment, so doctors may be able to remove the lump as soon as possible. In some cases, surgery is all that is necessary in breast cancer treatment when caught early enough. However, in the past 3 decades, doctors have also come to understand that many cases do require additional treatment after surgery in order to increase survival. Many patients are now prescribed tamoxifen, a selective estrogen receptor modulator, which helps reduce chances of the cancer recurring. Doctors have learned more about the development of tailored medical treatments in oncology through studying breast cancer. The characterization of steroid hormone receptors, including the estrogen receptor, also known as ER, and the progesterone receptor, also known as PR, in the 1960s soon led to the identification of these proteins as markers for endocrine treatment in breast cancer. Additionally, across the whole spectrum of breast disease, estrogen receptor expression has proved to be essential for the benefit from hormonal therapies. In 1972, the use of chemotherapy for advanced breast cancer was established, and results of adjuvant chemotherapy trials would emerge within a few years. Multiple cytotoxic agents are now recognized as preventing breast cancer, including alkylators, antimetabolites, topoisomerase inhibitors, and microtubule-targeted agents. Their application and treatment of early breast cancer has been carefully evaluated, and the success of these approaches has been documented through individual clinical trials. In 1996, testing for the BRCA1 and 2 gene became available to the public. This became the top indicator for genetic risk of breast cancer and likelihood of recurrence. Recent information also suggests that the status of the oncogene HER2 may be highly predictive of response to doxorubicin and may further select patients for this treatment. The implication of genetic testing for breast cancer has greatly improved chances of survival and the decided path of treatment, as patients with low genomic risk often do not require as severe adjuvant therapy. With all of these developments in treatment, the outlook after diagnosis of breast cancer has greatly improved. In 1975, the rate of death from breast cancer among women 30 to 79 years of age was 48.3 deaths per 100,000 women. By 1990, the rate had increased slightly to 49.7 per 100,000, but then fell to 38.0 per 100,000 by the year 2000, a decrease of 24% from 1990. The first form of treatment my mom received was a lumpectomy on her cancerous breast at age 34, along with removing 35 lymph nodes. Doctors told her she had invasive lobular carcinoma and that her case of breast cancer was extremely rare, yet slow growing. They told her that they felt comfortable after the surgery and targeted radiation treatment her cancer would not be likely to recur. Despite this, in 2002 my mom was diagnosed with breast cancer a second time. I'll let her discuss more what happened when she was diagnosed that second time.
The second time I was diagnosed was in December of 2002. And I found the lump myself, again in the same breast and in a different location. I had just had my second child. He was in February. And I'd had a mammogram maybe about 4 months after that because I was breastfeeding. They wanted to do a mammogram because I'd gone like a year without one because I was pregnant, to make sure there wasn't anything there, and it came back negative. There was nothing there. So when I found this lump about 4 months later, 5 months later, they'd already had something to look at that had just been a few months before that to compare it to, and I'd already had a tumor the size, like 1 centimeter, which was bigger than my first tumor, and it had to have shown up in like 3 or 4 months. So the doctor was very concerned. She said, I just remember they treated it all very differently. Like, this needs to come out right away, and I don't like the way this looks at all. So they removed it with a lumpectomy and got the results back quickly, and it wasn't a recurrence of my original cancer. It was called a second primary. This time I had invasive ductal instead of the first time I had invasive lobular. And this tumor itself was much faster growing and had a blood supply to it. They could see from the ultrasound, so in other words, it was growing.
The doctors ended up performing a mastectomy on my mom's cancerous breast soon after the lumpectomy. One thing I found interesting was my mom's recurrence of cancer the second time happened in a different area. This made me wonder if her previous cancer treatment could have triggered a more aggressive recurrence in a different spot, so I asked her if she thought the radiation could have been a proponent in the recurrence.
I've wondered that as time's gone on, that could the radiation treatment I had to my breast caused another type of cancer to form there if my body was more prone to making cancer. I used to call it my cancer factory.
When doing research, I had a tough time finding substantial evidence that radiation can cause a recurrence of breast cancer specifically. It has been found that there can be a link between recurrence in patients who are younger when they first receive radiation, so perhaps this could have affected the recurrence. In addition, doctors have been able to enhance the precision of their radiation in recent years, so this could be a contributing factor as well. It may very well be true that my mom's recurrence was an anomaly, as the doctors described it to her. The most interesting difference I found in the treatment of my mother's cancer the first time is the testing for BRCA1 and 2 genes was not yet available. They did test her for the second time, in which she was negative for the genes, but I still am in awe knowing doctors treated her without knowing her genomic risk, now that after research I know how big of an effect this can have on one's survival. Even after all of these discoveries and advancements, breast cancer is still very common. It is said that 1 in 8 American women will have breast cancer in their lifetime. However, survival rates for cancer have skyrocketed in recent years. The National Cancer Institute says the survival rate 5 years after diagnosis of breast cancer is 89.9% as of 2015. The most important factor in increasing survival rates of breast cancer is early detection. Even though breast cancer is more common in older women, women of all ages should administer self-examinations to check for lumps. Always check in with your doctor to be safe if you do find a lump. Now, as I close off, I will leave you all with some final thoughts from my mom.
And it just kind of opened my mind to everybody has things happening in their life that you may not know about that's really stressful and anxiety provoking, and you should be more open to people around you and how your actions affect other people and how other people's actions affect. I just opened me up to a clearer way of thinking that I don't think I ever would have discovered had that not happened to me. It was a profound experience, life-changing experience.